We are live, everyone. Good evening. Welcome to this 48th chapter in the series of masterclasses brought to you by the Academic Council of IASO. Topic for today is pelvic girdle tumors. I invite our Academic Council advisor, Dr. Saraswam sir, to kindly deliver the welcome address for today's webinar. Sir.
Good evening, everybody. Under the IASO Academics Masterclass series, after a gap of a few months, today's discussion will be on pelvic girdle tumor. And the examiners are the very learned people, Dr. Manish Mumbai, and the moderator, Abid Salunke from Ahmedabad. And the Manish Pruthi is Associate Professor of Orthopedic Oncology, Tata Memorial Hospital, Mumbai. He had his undergraduate Delhi and MS Ortho at PJ Chandigarh and Dipanbi Ortho. Fellowship in MSK, TMH Mumbai, and Diploma of Tissue Banking, NUS, Singapore. Welcome, sir. And Abhijit Salunke, welcome you again. As an orthopedic oncologist, GCR Ahmedabad, alumni of TMH Mumbai and National University Hospital Singapore, author and reviewer of multiple international journals. Thank you for participating and welcome you.
Thank you, sir.
And Srijan?
Yeah.
Thank you very much, sir.
Thank you so much,
welcome
sir.
One and all, and I welcome the examinees also. Wish you all the best.
Thank you, sir.
For the examination. My greetings to everyone here. Subbu, particularly, who has taken a lot of interest, and Srijan Shukla, of course, the star performer of the day. Thank you, one and all. Let me welcome all of you on behalf of the IASO. Thank you.
Thank you so much, sir. Thank you so much. The examinees for today are Dr. Sarfaraz Ahmed, who's a resident in the Department of Surgical Oncology at HCG Ahmedabad, and Dr. Nikhil Tiwari, who's from AIMS Jodhpur, Department of Surgical Oncology. Few instructions for our session to both our examinees, Dr. Sarfaraz and Dr. Nikhil. We expect that you give to-the-point answers to the questions that are being asked. If you don't know something, kindly mention it and we can move forward. It saves us time. And do catch the hints that the examiners will be giving either by their words or by their face or their expressions. Okay. To our moderator for today, Dr. Abhijit, we request you that you address the examinee by their name. So Dr. Sarfaraz and Dr. Nikhil, to avoid confusion amongst them who's supposed to answer.
Okay.
And we request you to ensure that both of them get equal opportunity to shine.
Yes, definitely.
To both of examiners, Dr. Abhijit and Dr. Manish, we have a lot of online viewers, both who are live today here on YouTube, as well as some people will be viewing it later on YouTube. So unlike an actual exam, we request you to give the expected answers to the questions that remain unanswered or have been incorrectly answered. For the participants, senior ISO members, thank you so much for logging in and posting your inputs in the chat box as well. And to all the residents out here, it's a difficult topic for a surgical oncology resident. I speak from my experience. So it's a very unique opportunity to clear all your doubts and it will help you a long way in preparing for your exam as well as in real life. For the first session, which is the case discussion, I'll be reminding the moderator at 30 minutes, 45 minutes, and an hour via chat. And at 1 hour, I'll also unmute myself and remind. Thank you so much. And over to you, Dr. Abhijit.
Yeah, I am sharing my screens.
Please.
So Srijan, like before Dr. Abhijit starts his presentation and the case discussion. So I just want to know, like, how often in a surgical oncology exam that you get a pelvic tumor case?
If there is a case, it is actually kept.
Okay, it is kept.
It's not a very common thing, you know that. Manish,
So it depends to the incidence, and if you have a
in that area. If you
Okay.
have a strong consultant like Manish or Abhijit, you will have cases.
Sure, sir. That is first thing. And second thing, I want to know which year these residents are. So Sarfaraz and Nikhil can update on them. Like, I have no.
So I'm a third year resident, sir.
Okay, Sarfaraz, great. Third year surgical oncology. Yeah.
Yes, sir.
Final year. Yeah.
Sir, I am a second year surgical onco resident, sir.
Great. Great, Nikhil. So we'll be asking you questions, but if you have any doubt, any clarification you need in the question, you can easily discuss, because today it's a mock exam. So don't get scared. Just open your mind and think before you speak. Okay?
Yes, sir. Yeah.
Good evening, sir.
Great.
Yeah.
Good evening.
Good evening. Thanks, Dr. Rao sir and Dr. Srijan, for considering me to be a part of this program. So, greetings from GCRI, Gujarat Cancer Research Institute, Ahmedabad. So, just at the start, I will want to share that we are arranging a conference in June 24th and 25th. So, it's a 4th Onco Orthocon. And the key topics of this will be, again, pelvic tumors, the topic of today's relevance. So day 1 will be focusing on pelvic and sacrum tumors, and day 2 will be focusing on the recent advances, which includes 3D printing, AR and VR. So we'll go directly to the case. So this is a case 1, 22 years gentleman, a student by occupation, pain in right inguinal region for 3 months duration, swelling over right inguinal region for 2 months duration, and there is no other significant history. So this is the history of the patient. And this is the clinical examination, what we had checked for you, that this is the patient lying supine on the bed. And what are the points we need to ask the patient? So Dr. Sarfaraz, what points you would like to ask? Other points I had showed you that this is the history what we are giving here, pain and swelling, and there is no other significant history. So how you elaborate on pain and swelling for this case? So this is the clinical picture of the patient.
Yes, sir. So first, I will go to elaborate the history of the pain, whether it is intermittent pain, dilating pain, or intermittent or continuous, or dilating or throbbing type of pain, sir. First, so the site right inguinal lesion. So obviously, young age, I will have to rule out hernia first, sir. Then I will have to rule out any enlarged lymphadenopathy. Along with, I will have to take a history of fever that may lead into any infective pathology. Then if nature of the pain is dilating, boring type pain, then I will have to go for the soft tissue and bony part, sir. So if heart and there is heart.
No. Sarfaraz, wait.
Yes, sir.
So I think we'll not jump into examination. Okay.
Yes, sir.
So let's focus only on the history as of now.
Yes,
okay,
sir.
So your patient is having a pain for 3 months and the swelling in the inguinal area for 2 months.
2 months, yes, sir.
Fine. And Dr. Abhijit has written there is no other significant history. That means there is no history of fever. Okay. And,
yes,
and there is no significant family history and no significant past history or a treatment history.
Yes, sir.
Fine. So with this history, I just want to know, like, what are you thinking in your mind? Okay, as you have said that you need to know the character of the pain.
Yes, sir.
Okay, so we can ask Dr. Abhijit what was the character of pain, so that you have a much more qualifying information for you to make a mental impression what we are going to deal with or what
yes,
we are
sir.
dealing with.
Yes,
Dr. Abhijit, can you elaborate a little more?
It was a dull aching pain.
Yeah.
Dull aching pain was there, and patient had to take some medications after few days that he was taking a painkiller, anti-inflammatory drugs. He consulted an orthopedic surgeon and it got partially relieved. It didn't get completely relieved. So it was a dull aching pain, partially relieved by medications.
And
yes,
no fever. No fever.
No fever. No other history.
So, and was the patient still able to walk with the pain?
Yes, patient was still able to walk. So patient was still able to walk. So we show a walking video, how he was walking. He was having big pain on walking.
And whether he was able to carry out his day-to-day activities.
He was able to carry all his activities of daily living.
He was able to walk full weight bearing.
Yeah, he was able to walk full weight bearing.
And no constitutional symptoms.
No other constitutional symptoms.
So, Sarfaraz,
yes,
now we know a little bit more about the history.
Yes,
So
sir.
with this history, like what are you thinking in your mind before we move to examination? You have to make a mental impression whether you are dealing with an infective pathology or a congenital problem or a traumatic pathology or tumor. So you have to think about what are you dealing with, what you are going to find in examination,
So,
or you are
sir,
dealing with an hernia. Yeah.
so dilating pain, sir, which relieved on medication, sir. So, points more towards, sir, tumor pathology, sir.
Okay. So what kind of tumor you are thinking about?
So it may be, sir, soft tissue sarcoma or, sir, underlying bone tumor, sir.
So you are thinking about a malignant tumor or a benign tumor?
3 months history, sir, short history. So most likely to be, sir, point towards a malignant history, sir.
So basically, in 2-3 months history, you are thinking either of a soft tissue sarcoma or a malignant tumor. That is what you want to say.
Yes, sir.
But why you are not thinking anything about an infective etiology?
So infectivity, sir, there is no history of, sir, fever, sir.
So what infection you will think that can happen in this area?
So tubercular,
Tuberculosis of what region?
tuberculosis of the inguinal lymph nodes or, sir, tuberculosis of the hip bone, sir.
So how common is that a bone tuberculosis will lead to fever?
Sir, generally there is no fever, sir.
So that is why. So can you rule out a tuberculosis here based only on the history of fever?
No, sir. Other constitutional symptoms should be there, sir, like weight loss, anorexia, but these are absent, sir.
But usually in bone tuberculosis, you will not see that.
Okay, sir.
Yeah. So,
Yeah.
so with this kind of a history, so you cannot totally rule out an infective pathology here.
Yes, sir.
Okay.
Okay,
And may I ask Nikhil, if there is a history of pain which precedes the swelling, so what kind of tumors you will consider first?
Pain preceding the swelling favors more it's in more favor of a bony origin rather than soft tissue sarcoma, sir.
Yes, so that is exactly. So that is surface we should know that now the patient is having a longer history of pain than the swelling, and most likely the soft tissue sarcoma presents as a painless swelling to start with,
Okay,
unless they stretch some tissue, some nerve, okay, or involve the periosteum of the bone. So then only they become painful. So mostly the soft tissue sarcoma, it is just a general rule. Okay,
okay,
the
sir.
soft tissue sarcoma will present with the swelling first rather than the pain, while a bone tumor will present with pain first.
Okay, sir.
So fine, when there is a painful swelling now, yeah. So that is based on the history. So I think we are thinking about an aggressive pathology if there is a tumor, okay, or we are thinking about an infection because there is no other significant history here.
Yes, sir.
So suppose, yeah, Abhijit, yeah, go ahead.
So Nikhil, you want to examine this patient. So what will be the steps of your examination? Means this patient you are seeing now. So this is a clinical picture what we are showing you. His parts are exposed, whatever parts you want to examine. So what are the steps? What is the first step, second step, third step to examine this patient you want to evaluate?
Sir, patient should be examined in a well-lit room after adequate exposure.
So this
And
looks to you well lit.
yes,
This looks okay. So this is the patient lying. So just you can describe the inspectory finding what you are seeing here.
sir, on inspection, there appears to be fullness over the right inguinal region, approximately like extending from the pubic symphysis up to or nearly up to the ASIS, and I can see a visible scar over the swelling, likely biopsy site, and there are no signs of inflammation like erythema, dilated veins that are visible, sir.
Yes. So
No other scars or sinuses visible.
yeah. So these are the inspectory findings what you are
Yes.
seeing. Yeah.
Sir.
So Sarfraz, do you want to add anything extra what Nikhil has said, or this is okay with you on inspection?
Sir, there seems to be, sir, right thigh seems to be enlarged, sir, or engorged compared to the left side, sir.
Yes. So that is one finding. So it looks a bit swollen as compared to other side.
Yes, sir.
So I think Nikhil, like before we go to the local swelling in any limb case, okay. So first thing that you have to tell is the attitude of the limb. Okay. So you need to tell that there is no exaggerated lumbar lordosis if there is something around the hip area. You have to tell the position of the hip, knee, and the ankle. Okay, because that gives a very useful information. Like suppose this is now a swelling in the inguinal area. Suppose it is causing irritation of the psoas and it will cause a flexion of the hip because of a irritation of the muscles. So the first thing that you have to tell before you jump to a local inspection of the swelling is the attitude or the position of the limb. So do not forget to tell that. Okay. So first thing here will be that it is not very clearly visible, but still you should attempt to. You should not miss that. The attitude of the limb is very important. You say there is no exaggerated lumbar lordosis. The hip is kept in neutral flexion, extension, abduction, abduction, and whatever the knee and the ankle position is. We can't see that, but that is the first thing that you will start. And in inspection, you have told about the mediolateral extent, but you have not tried to tell us about the superior inferior extent. Okay, so looks like the swelling is ending above the inguinal ligament. That much we can say, but proximally we don't know. It is merging with the abdomen. So you have to tell in both the directions, mediolateral as well as superior inferior. Okay.
Okay, sir.
Yeah. So this is on inspection. So this is a small video. Sarfaraz, you just see the video and tell us what points you are seeing, and you can describe this then. So just I'm playing the video, small video. So you can see the attitude of the limb. So lordosis we have shown. Yes, Sarfaraz, just can you describe what was shown in the video and how you examine the patient by palpation and other things?
So in the video, the marking has been done on the greater trochanter, sir, laterally.
You can describe, just the video will run. You describe your findings.
Yes, sir. There is a
so start with tenderness and temperature.
Yes, sir. So first, there is a temperature we have to check, sir. So there may be rise of temperature or not, sir. And their symptoms does not seem to be tender, sir, because you are palpating and he is not complaining anything, sir. And now we have to confirm the position of the swelling in relation to the fixed bony landmarks, sir.
So what important landmarks think you here are there? Which landmarks?
Sir, here, sir, medially, sir, pubic symphysis, laterally, sir, greater trochanter, and more laterally and superiorly will be, sir, anterior-superior iliac spine, sir.
So, Sarfaraz, can you palpate the pubic symphysis?
No, sir. Just we had.
You have told. No, you have told medially it will be symphysis pubis. So, is symphysis pubis a landmark, or there is a better landmark that you can palpate?
So pubic tubercle, sir. Pubic tubercle.
Yes. So symphysis pubis is not a landmark. Okay.
Yes,
you cannot palpate symphysis. You can palpate a pubic tubercle.
Yes.
So your landmark on the medial side will be pubic tubercle on clinical palpation. Okay.
Yes, sir. Yes, sir.
Yeah.
Yeah, Nikhil, what was the gait of the patient? How you think the gait of the patient? Nikhil?
Gait appears normal, sir.
Gait appears normal.
So does that suggest something to you, Nikhil, like a normal gait with a swelling there? So what location that we are looking into, or does that help us examining the gait of the patient?
Yes, if the patient had presented with history of pain, so if the pain is severe enough and if the patient is not able to bear weight, likely an impending pathological fracture or if anything is expected, the patient will have antalgic gait. Or if the patient, if there's any neurological infiltration, the patient can have weakness in the flexion of the
Dr.
thigh.
Manish want to ask that whether joint is involved or not. His intent is which part of the bone is involved. So you want to go towards the diagnosis. So whether hip joint is involved or not, acetabulum or femoral head is involved or not. So we'll tell you something about that.
If there is involvement of the hip joint, the patient can have irritation of the like in the joint cartilage and can have pain. That will also result in like it will affect the gait of the patient.
Yeah, very correctly, Nikhil. I think you have mentioned all the points. First thing is a fracture or an impending fracture. Second thing is the neurological involvement. And third, as Dr. Abhijit has pointed, the joint involvement. So all this will cause a trouble in the gait or an abnormality in the gait. The type of abnormality depends upon the type of pathology, okay, or the type of problem that is happening inside. That's fine, I think. But yes, the seeing a normal gait reassures us a little bit that okay, it is not infiltrating the major structures, or it is not at a risk of fracture, or the joint is still appears normal. Yeah.
Yes. So, Sarfaraz, what is the next investigation? You have examined the patient. You have made
No. Wait, Abhijit, wait.
Yes.
Sarfaraz, now you have examined the patient. Okay. And
Yes, sir.
do you want to know something more about examination from Dr. Abhijit? You have some more points to clarify, or you want to give differentials now?
Sir, just I want to know what is the swelling, whether it is hard.
So it was a firm swelling, a hard swelling was there.
Okay, sir.
So Abhijit, is firm or it is hard?
It
Or
is
firm
firm
to
swelling.
hard?
It's a firm swelling.
It's a firm swelling.
Firm swelling.
Okay. So Sarfaraz, why do you want to ask that?
So just to confirm, sir, whether it is pertaining to the soft tissue part in the inguinal lesion, or it is a deep-seated lesion or bony lesion, sir. To know that, sir.
No. The swelling that you are palpating is what you are able to palpate.
Yes, sir.
Okay, we are not talking about deep-seated lesion or something. You are able to palpate a swelling.
Yes, sir.
And you want to know whether it is firm or hard.
Yes, sir.
Am I correct?
Yes, sir.
Yeah. So why do you want to know that?
Sir, if it is a hard, then probably it is originating from the bone, sir. And it is firm, then it is originating from the soft tissue, sir.
Okay. Nikhil, you want to add something on that, or you are happy with the answer? Nikhil is gone?
No, I'm there, sir.
Yeah.
So any other examination findings? You have seen the gait, you have seen inspection palpation. Any other thing I had missed here? I had not shown here.
Sir, I want to know if there are any other swellings apart from the
There are no other swellings. No, related to that local part. Right hip joint movement we are not shown. So here we are not shown the hip joint movement. He's walking well, we assume that his movements are okay. We are not shown his knee movement. We are not shown his distal pulsations.
Yes, sir, distal pulsation.
Yeah, neurology we are not shown in this.
So let me come back to my question again. So Nikhil, you are happy with the answer that a hard swelling will be from bone and a firm swelling will be from soft tissue?
No, sir, not specifically, because even soft tissue sarcomas can be hard enough. So clinically, by just examining, depending on the hardness, it's difficult to tell whether it's from a soft tissue or if it's from a bone.
Okay, let's go back to basics. Like, how does SDAS describe the hard swelling? What is the hard swelling in SDAS?
Hard swelling is bony hard.
Bone, like you are palpating an iliac crest or an ASIS, okay,
yes.
or your ulna, medial border of ulna. So tell me, in a bone tumor, suppose it's a bone tumor, okay, what are you palpating in a bone tumor when there is a swelling? What are you palpating? Are you palpating the bone?
No,
or
sir.
are you palpating something else?
The soft tissue covering the bone, sir.
So you are actually palpating the soft tissue component of the tumor. Fine, because the bone tumor will cause a soft tissue component, and what you are palpating as a swelling will be a soft tissue component of the tumor. So very rarely you will feel in this small history a hard swelling, which can actually point towards a bone tumor. So most of the high grade bone tumors, I'm not talking about a low grade parosteal osteosarcoma. Okay. Most of the high grade bone tumors, which you are thinking about a malignant bone tumors, aggressive with a short history, will be firm swelling, will not be hard. Okay. A hard bone swelling will be an osteochondroma, which is a benign tumor, which will be there for years. Okay. But an osteosarcoma, high grade, a chondrosarcoma, Ewing sarcoma, all will be firm. They will not be hard. Okay, the hard bone tumors are parosteal osteosarcoma, which is a very low grade osteosarcoma, but then you will have a history of years. You will not have history of months. Okay, so per se, knowing the type of swelling, firm versus hard, will not qualify much in terms of differentiating whether you are dealing with a bone or a soft tissue tumor. That is what I just want to tell you. And now what Dr. Abhijit is saying, like seeing the distal neurological status. Okay, why it is relevant?
So, bone tumor or soft tissue tumor can encroach onto the nearby neurovascular bundle.
Okay, so what will you look into? Let's straight away jump into what will you see?
Sir, in this case, I will have to see the distal popliteal or dorsalis pedis artery pulsation, sir, to know femoral artery pulsation, sir.
So femoral artery pulsation, how often you will see that the arteries are so compromised that you will not get the pulsations? Uncommon. Very rare. So I think pulsation does not make much sense. So what else you want to see? Nikhil, you want to add?
Sir, distal pulsations I would like to look for. Mainly,
that is what I am saying, Nikhil. The artery is such a high flow system. It will be very rare you to lose a pulsation because you will have an ischemic limb otherwise.
Sir, not in this case specific. Sir, if the patient is elderly.
So in this case only we are talking. What will you look to assess the neurovascular status or to know that the tumor is involving that?
I would like to look for the if the patient is having any neurological deficits.
Okay, what neurological deficit do you expect here?
In this patient with a likely pelvic tumor, there could be nerves affected in the form of sciatic nerve, femoral nerve, or obturator nerve. So
no, Nikhil. Nikhil, wait. There is an order. Okay, you are palpating a swelling in the groin, in the anterior part.
Sir.
And why you are so worried about the sciatic nerve? Are you feeling a swelling in the gluteal area?
No, unlikely.
And you are not feeling a swelling which is deep down, which is going right up to the umbilicus or right very high above, which is having a big soft tissue component deep? No. So basically, I think if you have to do any neurological examination, it should be femoral nerve first, then obturator or sciatic. Okay, so you have to stay in order based on your case. Okay, you want to examine anything, you want to examine the radial nerve, but that doesn't matter here, na?
Sir.
Okay, so that is first thing you will see for the femoral nerve. How will you check for femoral nerve?
Sir, sensory and motor components. If the patient is having any paresthesia, or I would like to look for that. Check this over the anterior and lateral aspects of the thigh, sir. And
okay.
For sensation and motor in a form of hip flexion or knee extension, I would like to look for the movements.
Okay, so what is the Sarfaraz? What is the primary hip flexor?
Primary hip flexors are psoas major muscle and pectineus muscle.
Psoas major, and psoas major is supplied by femoral nerve?
No, sir.
So Nikhil wants to check for hip flexion for involvement of femoral nerve. So Nikhil, if this tumor is involving the femoral nerve, where it is involving? Just above the inguinal ligament?
Yes, sir.
So what function will be affected? It will be quadriceps.
Sir.
So basically, you need to see, if you need to examine a femoral nerve here, you need to see the knee extension, not the hip flexion. Okay, rectus femoris is a secondary hip flexor, the straight head, which comes from the anterior inferior iliac spine. But that is a very minor hip flexor as compared to a psoas, iliopsoas. Okay, and if femoral nerve is involved in this tumor, you will lose the knee extension. And going back to the question which I asked to Sarfaraz, that more than the artery, what you will see is the pedal edema, because the vein will be compressed first.
Yes.
And if you are seeing a pedal edema, then you are worried that, okay, I might see a neurovascular compression or maybe a partial encasement in the imaging, but most likely you will not lose a pulsation, because if the patient has come to you walking, okay, without
Yes,
an
sir.
ischemic symptoms in the limb, then most likely the femoral, okay, for documentation, you can say the femoral artery, the distal pulses are fine. But what is relevant here is seeing for pedal edema. Okay.
Okay,
And
sir.
seeing for femoral nerve function. So I think in an exam, what we want to know is whether you are understanding the case or not. Okay. We
Okay,
want
sir.
to know that, okay, you are in the case or you are just talking about general things. Okay, which does not make much sense. So now, like Dr. Abhijit,
Summarize the case. So you can summarize the case according to your clinical findings, sir, for us. So clinically, what it looks to you, and just you can summarize the case for everyone.
Yes, sir. So 22-year male gentleman with history of 3 months history of pain in the right iliac fossa and swelling on the right side, right iliac fossa for last 2 months without any significant comorbidity or associated symptoms, with firm swelling in the right iliac fossa.
And clinical findings, you can just summarize in one
Yes,
line
sir.
or 2 lines, so everyone can understand what you want to say.
Without any history of neurovascular deficit.
Yeah, so a firm swelling in right inguinal region with distal pulsations normal, neurology normal, patient walking well.
Yes.
So Nikhil, what is the next investigation you would like to do for this patient?
Sir,
Abhijit, let's ask differentials to them. What
Yeah, so
they are
differential
thinking.
diagnosis.
So because I think they need to go, they need to understand what they are dealing with. Okay, and is it fixed to the bone? The swelling?
Yeah, fixed to the bone.
Fixed to the bone. So, okay, Nikhil, so it's a swelling which is fixed to the bone, firm swelling in the inguinal area, whatever
short
dimensions.
duration history.
Short duration history. So what are you thinking?
Differentials 1, 2, 3.
Sir, in this patient with young male who presented with pain preceding the swelling and no associated features of inflammation or infections, and with a short history, this looks more like a malignant etiology, better than infection. Looks like a malignant etiology, and with a short history, likely to be in the region and in this age group looks more like of a chondrosarcoma.
So your first differential will be chondrosarcoma. Any other differentials you would like to take? So one is chondrosarcoma, then second.
Like other bone tumors, I'd like to consider like osteosarcoma or Ewing sarcoma. Also, I'd like to consider as a differential the chronic osteomyelitis, which could still be a possibility.
So first is chondrosarcoma, second osteosarcoma, third Ewing's, and fourth less likely infection.
Yeah.
So Sarfaraz, you agree with Nikhil or you want to add on something? Nikhil, it's okay. Forget the differential. If I ask you to give a diagnosis here, okay. So what is your one-line diagnosis?
Right-sided inguinal mass, likely neoplastic, and most probably malignant etiology.
So malignant, okay, neoplasm of right iliac region, okay, and your differentials are either chondrosarcoma, osteo, Ewing's, and second differential is chronic osteomyelitis.
Sir.
Yeah. So Sarfaraz, you want to add on that?
So we can also keep, sir, benign lesion also we can keep in our differentials, sir.
What benign? So which benign tumor will give you present with a 3 months history, Sarfaraz? No, you only
Okay, sir.
said. I am just asking you.
No, sir. I don't know, sir.
So can
But, probably-
osteochondroma, it can be osteochondroma surface.
Okay, sir.
Can it
No,
be
no,
osteochondroma which has
No.
just acutely increased in size and painful? Can it be or can't it be? Osteochondroma.
No, sir. I don't have that much knowledge, sir.
No worries. So osteochondroma is a benign tumor surface which
Yes.
grows till the time of skeletal maturity because it is a growth cartilage. And usually it stops growing after skeletal maturity. So what Dr. Abhijit is saying is usually like if there's an osteochondroma there, it usually should have grown till skeletal maturity. But now it should have stopped growing.
Yes, sir.
Okay. So Nikhil, I think I partly agree with you that you are suspecting a malignant neoplasm of right iliac region. Okay, but I think you need to qualify it a little more. I think at this age we should suspect a primary malignant neoplasm rather than a metastatic. So if I ask you, I think you should tell about primary malignant. And I am not very much interested in differentials because if you give differential, then it will be a trouble. Okay, and you can say in differential, sir, my first differential will be a primary bone sarcoma. So don't give a histological diagnosis as of now. And have you completely ruled out the soft tissue sarcoma here because you have not given that differential? So because it's a firm swelling in the inguinal area, deep seated. So there many of the time you see a retroperitoneal sarcoma present there. And on clinical examination, I think it will be very difficult for you to differentiate whether it's a bone versus a soft tissue because the structures are so fixed that the mobility will be limited. So I think I cannot rule out based on the examination a soft tissue sarcoma, which is present there in that groin area, in the suprapubic area, in the suprainguinal ligament area. So I think my first diagnosis, if I'm calling a bone tumor, then my second will be a soft tissue sarcoma. Why can't it be a lymphoma there? Just asking. Yeah.
Primary bone lymphomas are rare, but still a possibility, sir. It could be.
So that is why I am saying you don't go into an histological diagnosis. But yes, if it was a like a swelling in the inguinal area, which is an inguinal lymphadenopathy, then you should have seen a multiple lymphadenopathies. Yes. Okay, in a primary lymphomas, not of the bone, you will see a multifocal lymphadenopathy. So you need to examine all other regions, okay, because it's a firm swelling in the inguinal area. Okay, so you need to examine the nodes at other regions. And I think Dr. Abhijit mentioned about swelling in the other parts of body. Okay, what is the relevance here?
Sir, to notice metastatic foci, sir.
So 22 years you are suspecting a metastasis, Sarfaraz?
Sir, metastasis from the primary bone site, sir.
That's likely.
No, so metastasis from primary bone site. Okay, great. So suppose this is a chondrosarcoma. So what is the most common site of a chondrosarcoma metastasis? For osteosarcoma or E-wings?
Lung, sir.
Lung. So will you be able to palpate a lung?
No, sir.
So then why do you want to know about other swellings in the body? So we are actually getting the message, like we are 30 minutes up. So I'll just tell you, I'll go before Abhijit shows the X-ray. So basically you want to rule out a hereditary multiple exostosis, okay, which can cause a secondary chondrosarcoma. Fine. You want to rule out a neurofibromatosis, which can cause a malignant peripheral nerve sheath tumor, which can arise in the femoral nerve area.
Okay, sir.
Fine. So these are the two pathologies which show the multifocal bone swelling or a soft tissue swelling, and which can lead to a primary malignant or a soft tissue tumor. So that is why you want to see the swelling, swellings at other sites of the body. Okay, Abhijit, please go ahead.
Yeah, Nikhil. So as in any exam, what is the next investigation of choice? So here it's a X-ray in any orthopedic case. So this was the X-ray. So how will you read a X-ray for us? So the examiner asks in your final exam, you want to read this X-ray. So what is your pattern of reading the X-ray?
So the X-ray shows the X-ray of the pelvic in AP view, plain. It's a plain X-ray, and along with that, bilateral hip joints are exposed. In this X-ray, we look for the bony continuity in the form of lines, mainly the ilioischial line, iliopectineal line, Shenton's line. In this, there is some like irregularity in the iliopectineal line, and also I can see a lytic lesion involving the around the right periacetabular area with internal small spiculated calcifications.
So, Sarfaraz, you want to add anything extra here?
No, sir. Already mentioned everything, sir.
So, do you think the patient is skeletally mature or immature? Here?
Mature, sir.
Mature. So, that is the first point what should be said. So, age of the patient, first point. Second is which bone is involved. So, here which bone is involved, you think?
So periacetabular region, sir, mainly.
Periacetabular region. So, which bone is that? Ilium, ischium, pubic bone.
It involving, sir, parts of ilium, ischium, and pubic bone, sir.
Pubic bone. Next, third is the content. What Nikhil said, it looks to him a bit lytic and some areas of sclerotic.
Yes, sir.
Next is how it is distributed. Well defined or ill defined?
Ill defined, sir.
It's ill defined or well defined?
Ill defined, sir.
Ill defined. E exterior, any soft tissue mass, any periosteal reaction? Here you can appreciate.
Some soft
Yes.
tissue mass is seen, sir.
Soft tissue mass. Is there any fracture?
Sir,
No fracture seen.
no, sir.
No fracture seen. Do you think the joint is involved here?
Sir, joint seems to be free, sir.
Joint seems to be free. So this is one X-ray what we are showing here. This is second X-ray. So what is this X-ray here on the left side? So we are seeing the hip joint, femur and whole knee, whole leg is seen.
Yes, sir.
So this is a scanogram. So you need to get an X-ray which shows upper joint and lower joints. So it's always a good idea that any other swellings are here or not. And here there is a simple method to read any X-ray. So we publish it as A to Z RAM, what I said. So A is for age of the patient, B is for bone, which bone is involved, C is for content, characteristic, D is for distribution, E is exterior, F is for fracture, and Z is for zone of transition. So in any X-ray, so this was the X-ray. So you can summarize this X-ray in one single line. In exam, you can't say A, B, C, D, E, F, Z. So you can summarize here a radiograph of a skeletally mature individual showing a lesion in iliac bone with ischium bone, which is osteolytic, which is ill-defined, with wide zone of transition, with a soft tissue mass. So radiologically, it looks to be of a malignant bone tumor. That should be your line. And again, the examiner asks, what is your differential diagnosis? Then you can say 1, 2, or 3, whatever you want to say. So you can summarize any X-ray in one single line.
So Nikhil, what are your differentials here now?
Sir, in this with not so well defined transition zone and lytic lesion with few.
Nikhil, wo sab ho gaya. All that is done. Tell me the differential diagnosis or diagnosis. Whatever you want to tell me.
Contour matrix with a chondrosarcoma, sir.
Arey bhai, don't jump. Let me ask you another question. Na? So that is, I think you can guide the examiners also sometimes to ask you more questions and you can answer correctly. Fine. So you can tell primary malignant bone tumors.
Bone tumor. Okay. Yes, sir.
So if you tell this, I think you will be correct. If you call this as a primary malignant bone tumor here, you will be correct. And then I will ask you another question. Okay, what are your differentials then in primary malignant bone tumor?
Sir.
Fine. Then you can qualify. Okay, sir. Based on the type of matrix. Okay. I think that it is most likely a chondrosarcoma or osteosarcoma or no matrix even. But I think saying a correct answer makes more sense. Okay. Because I think at with your understanding and your experience, it will be very difficult for you to differentiate between a chondroid and an osteoid matrix. Sometimes you can be absolutely wrong. It could be an osteosarcoma and you will say, I am seeing a chondroid matrix. But more or less, you will be correct if you call it as a primary malignant bone tumor. You will not be wrong.
Sir.
Fine. So just call it as a primary malignant bone tumor, and my differentials either osteo or chondro, whatever you want to say. Okay.
Yes.
Abhijit, you want to add something
Yeah.
more?
So Sarfraz, what is the next investigation you want then for this case?
So next investigation, I will go for sir, MRI. Sir. MRI pelvis, which
Any blood test you want here? Blood test?
Blood test, sir, we can do for sir CBC.
Yeah.
Then alkaline phosphatase.
Yeah.
LDH, total protein,
Yeah.
and fraction, and serum creatinine and serum calcium.
Okay. So the patient
Well,
presented to us with a CT
wait.
scan. This is a CT scan what he presented to us.
Abhijit, let him tell now why he wants to do all these investigations. He wants to do a
Okay,
list of investigation. He
yes,
can
so
ask.
justify your investigations. Why
He could have
CRP,
asked
why
for, he
LDH?
could have asked for CA also, PSA also. So why do you want to do alkaline phosphatase?
Sir, alkaline phosphatase, sir, if there is a bony destruction, sir, then alkaline phosphatase may elevate in the serum, sir.
So definitely there's a bony destruction we can see in the X-ray. So you
Yes,
can
sir.
see a bony destruction in the X-ray.
Yes, sir.
So definitely alkaline phosphatase will be a little bit raised.
Yes, sir.
But does it help you anyway?
No, sir.
So how much it costs?
Approximately 400 to 500, sir.
400 rupees. So you are wasting 400 rupees of a patient. So now tell me, why do you want to do LDH?
Sir, it's also elevated in sir bony pathology, sir.
Okay, so whatever it is, but does it qualify you into something? Does it help you in a treatment planning or outcome?
No, sir.
No. So anyway, you don't need an LDH also. And what else you want then?
The CBC.
CBC you definitely need. Why?
Yes, sir. So because
it's a general test, na?
General test, sir.
So,
Yeah.
Because you need it for if you are planning a biopsy or something, you need to know the basic status of the patient. Okay.
Patient, yes, sir.
What else do you need?
Serum creatinine, sir.
Why?
Sir, to know the renal function, and if we are planning for further investigation, to know the renal status.
So you don't want to prick your patient twice. Okay.
Yes, sir. Yeah.
And you know that you have to do a biopsy. So if I ask you the investigation, I think you should ask for a CBC, serum creatinine, viral markers, and a coagulation profile.
Yes, sir.
I think these are more relevant investigation than asking for alkaline phosphatase and LDH at this level. Okay, because ultimately you are planning to do a biopsy.
Yeah.
Because without biopsy and for biopsy you need a viral marker as well as you need a coagulation profile.
Yes, sir.
So it makes more sense to ask more relevant investigation rather than some investigation which we are used in writing but it makes no sense. Okay, now Dr. Abhijit is showing you a CT scan.
Yeah, so Nikhil, this is a CT scan. So patient presented with all these investigations to us. So he has brought this investigation. He has brought a CT scan to you. So can you read this CT scan for us? So
the CT shows a contrast enhanced CT at the level of the hip joint. I can make out the left-sided head of femur along with the acetabulum. While on the right side, the acetabulum is not appreciated, and there is a lesion in the periacetabular region. Which is heterodense with multiple internal calcifications.
Great.
Yes, Sarfraz, any other findings you want to see here? The CT provides anything important here? It's okay with you?
Yes, sir. So soft tissue component of the tumor is approaching almost to the subcutaneous layer, sir.
Yeah.
And there is a tumor. There is mass effect of the tumor and pushing the content of the pelvis to the left side.
So, do you require MRI or a CT scan is okay with you now before biopsy? So you require a MRI or this is okay with you?
MRI is
MRI. So this was the MRI.
Wait. Sarfraz, why do you need an MRI in a bone tumor?
So in a bone tumor, the delineation of the MRI for soft tissue and bone marrow is better, sir.
Okay, so first thing is delineation. Okay, I'm noting down the point. Okay, delineation of bony and soft tissue extent. Okay,
yes,
is
sir.
better. Yeah. Okay, any other reason?
So another reason, sir, involvement of the neurovascular structures.
Perfect, very nice. So involvement of the neurovascular bundle. Okay,
Yes,
any other point?
Sir, bone marrow invasion.
Bone marrow invasion. How will an MRI tell you a bone marrow invasion? You have already told the delineation of soft tissue and bone.
Yes,
so
sir.
that means it is already telling us the extent in the bone. Okay,
sir. Yes. Okay, sir.
Yeah. So what else? Nikhil, what else?
Soft tissues and marrows.
So he has told, so I agree with him. First is extent of the lesion, which is the soft tissue extent as well as the bony extent. Okay, that is first. Second is involvement of neurovascular bundle. Okay. Any other thing that you want to do MRI for? We discussed in the clinical examination just now. A joint involvement.
Yes.
Okay. MRI can tell you about a joint invasion much better than a CT scan. Okay. So it will help you in joint involvement. What else?
No, sir.
No. So, and the most important thing is it will guide you in planning a biopsy site.
Yes, sir.
Okay. Because
okay,
you need to know your surgical plan. You need to know which part of tumor is necrotic. Okay. So all that information is required when you are doing a biopsy in a suspected bone or a soft tissue neoplasm. Otherwise, you will get a negative biopsy. Fine?
Okay, sir.
So
Thanks,
MRI
So
also
which type of biopsy you will do here? Open or a needle biopsy you will do here? This is the MRI of the patient. So which is the biopsy which is commonly done for these patients? Open biopsy or a needle biopsy?
Needle biopsy, sir.
Needle biopsy, and it's you can do directly or you require a CT scan here or a X-ray guided you want, image guided, ultrasound guided.
Yes, sir. We can guided biopsies are better, sir.
So any specific area you want to target here?
Sir, I don't know, sir.
And what is the line of incision? So what is significance of all these things? Open, needle, which area to target?
Yes, sir. So main importance is whenever we do a biopsy, it should be the small, very small incision if needed. It should be placed along the line of future definitive incision, and we should not contaminate more than more than one compartment, sir.
So just want to know, is this biopsy site correct here?
So Nikhil, this was a
Yes,
biopsy
sir.
site. What patient presented to you?
Nikhil, Sarfaraz, is this biopsy site correct?
Yes, sir. It is along the line of incision for definitive surgery. Sir.
Perfect. So your first two answers it qualify. It is a small biopsy and it falls in line. Okay.
Yes, sir. Yes, sir.
That both things it qualifies. Does it qualify into the third point that you have just mentioned? It should not contaminate more than one compartment. So where is where do you feel the femoral vessels will be here? That is an ASIS that Dr. Abhijit has marked above the greater trochanter, and the pubic tubercle will be somewhere at the medial point. So
yes,
biopsy
sir.
is right at the central part of that.
Yes, sir.
And what passes in the center of pubic tubercle to ASIS?
So femoral artery, sir.
Femoral artery. So does this biopsy close to the femoral neurovascular bundle? Yes or no?
Yes, sir.
Yes, sir.
So it could be going through the femoral sheath or next to the femoral sheath or around the femoral nerve, because the nerve is just lateral to the artery.
Yes, sir.
So is this biopsy correct then? The answer is no. No, the answer is no. As simple as that. So the basic rule is you should know about your incision, you should do a needle biopsy, all that is fine. But you cannot contaminate the main neurovascular bundle that you want to save. Fine. So the biopsy should have been placed more laterally, and we could have gone through the iliacus into the tumor.
Okay.
Fine. Or we could have gone through the anterior inferior spine into the tumor rather than going in the neurovascular bundle region. Okay.
Yes, sir.
So in this biopsy, if you palpate the femoral vessels, I am quite sure that the femoral vessels will be right below the biopsy site. We might have been lucky not to injure the vessels or just lateral to the vessels, but then it is a nerve.
Yes,
So
sir.
that means if you are trying to, if you plan to excise this biopsy scar, one of the structures is going to go. So to me, I think this biopsy site is not, although we have a needle biopsy, although it's fine, it is in the line of incision, but I think it should have been more lateral to protect the nerve and the major vessel, which is the most important structure if you are contemplating a surgery. Okay. Yeah.
So Nikhil, your biopsy is done. So this patient presented with a slide and blocks. So we reviewed it at our center, and the pathologist says it is chondroblastic osteosarcoma versus a chondrosarcoma. So they are not sure that what is their diagnosis. So what do you think here in this age group it will be more likely a chondroblastic osteosarcoma or a chondrosarcoma? You think which is more
As a patient,
better diagnosis here? Age is young, 22. So which tumors are more common in this age group? Chondrosarcoma or osteosarcoma?
Osteosarcomas are more common in this age group, sir, while chondrosarcomas are seen in 50 to 60 year age group.
So you were a bit wrong that chondrosarcoma, it can happen, rare of the rarest, but more likely to be a osteosarcoma, and of that also chondroblastic osteosarcoma. So your points that it is calcified and other things, so it favors more towards that side. So this is confirmed then chondroblastic osteosarcoma. What should be your next line of treatment, sir, for us? What do you want next for this patient?
So next we have to rule out, sir, we have to go for some metastatic workup, sir.
So this is the metastatic workup. So saving the time here, this
Yes,
patient presented with this also, PET scan.
So you are happy in doing a PET scan, Nikhil, in a staging of osteosarcoma, or you want to do something else?
NCCT chest would have been sufficient as a metastatic workup, sir.
NCCT chest. Sarfaraz, your answer?
Yes, sir. CCT chest and bone scan can be done, sir.
No. Now there is a confusion. You are saying CCT chest and bone scan.
No, CT scan, plain CT scan, chest and bone scan, sir.
You told CCT.
No,
you are correcting CCT. Yourself.
Yes, sir. Yes, sir.
So you need a plain CT chest, okay, or a non-contrast CT chest and a bone scan. Nikhil, yes, do you want to do bone scan or you are happy with only CT scan of the chest?
Only CT scan, sir.
Okay. So the staging investigation for osteosarcoma will be a non-contrast CT of the chest with a bone scan. Okay, because osteosarcoma can show an isolated bony metastasis without going to lung. Fine. So the investigation of choice will be both, not one. Okay, one is incomplete. Second thing is if patient comes with a PET CT, we accept that, but usually we don't order a PET CT in osteosarcoma. Now the patient has come with a PET CT, it covers both the bone as well as the lung. It should have a breath holding CT, but then it is fine. Okay.
So Nikhil, this is the PET CT scan. So what things you see here? Anything extra, any meds you see, or this is okay with you?
So let's just show the report to them, the PET CT report, and then we can discuss a little bit.
PET CT scan was just a tumor seen at that bone only, no other meds.
Wait. So now, Sarfaraz.
Yes, sir.
So it's a non-metastatic osteosarcoma of the pelvis.
Yes, sir.
In a 22-year-old male. Okay, so how do you want to proceed now?
Pose the patient for surgery. Yes, Sarfaraz?
No, sir. It is a multimodal treatment, sir. So first, I will go for, sir, neoadjuvant chemotherapy.
So why do you want to give neoadjuvant chemotherapy, sir?
Sir,
I want to operate him tomorrow.
Sir, because high-grade bone tumor are, sir, observe metastatic nature from the very beginning, sir. So if we
high grade bone tumor means chondrosarcoma is also high grade bone tumor. So please
sir,
qualify your statement.
Sir, osteosarcoma, as it is a high grade tumor, sir. So we have to treat the chance of micrometastasis at the very early period of the treatment
very
period,
good.
sir.
So you want to consider curing or taking care of the micrometastasis
First,
very
sir.
early in the treatment.
Yes, sir.
And then you want to operate.
Yes, sir.
So does giving an NSCT in osteosarcoma improves your survival? That means?
Yes, sir. It improves the survival.
It improves the survival. Okay. Nikhil, you want to do something else or you are happy with the answer?
Neoadjuvant chemotherapy should be given.
Should be given is one thing. Okay. NSCT should be given. That is one thing. Does it improve the survival or why do you want to give NSCT?
Giving neoadjuvant chemotherapy, it reduces the soft tissue component within the tumor, and it
in osteosarcoma, will it reduce the soft tissue component? I think no, because the tumor is going to mineralize. The soft tissue component is going to remain the same. It is going to be more ossified but not reduced. Okay, in Ewing sarcoma, I agree with your statement, but not in osteo. So why do you want to give chemotherapy in osteo then? Does it improve survival? The answer is either yes or no. We have to rush. Sorry, I can't hear you. Repeat. You are not sure. So first thing is the chemotherapy in osteosarcoma improves survival as compared to no chemotherapy. Okay, we had landmark trials by Link et al., which were like 1960s. Okay, which shows that the survival benefit, which says that 20% say it improved to 65%, giving chemotherapy in osteosarcoma. But per se, neoadjuvant chemotherapy improves the survival. There is no data for that. Okay, so giving all chemotherapy in adjuvant setting also gives you a similar survival as giving an NSCT, surgery and adjuvant chemo. Then why do you want to give NSCT if it is not improving the survival?
We can plan for the surgery. It will provide us time for planning for the surgery, sir.
So I have planned it with the images that Abhijit has shown. I don't need more time.
So we can assess the tumor response to chemotherapy.
Okay, and how does that help you? See, everything should have a significance. It is not like you want to do alkaline phosphatase without a significance. You want to assess the tumor response, I agree. But what is the significance of assessing the response? So the most important prognostic factor in osteosarcoma, okay, apart from a metastatic disease at presentation, is response to neoadjuvant chemotherapy. Okay, the people who have a good response, which we technically consider as a more than 90% response, have usually better survival as compared to poor responders to chemotherapy. Okay, that is one thing that you can prognosticate a patient. Okay, that is one. Second, what else it can help you? So I agree with Sarfaraz partly. Suppose you need to make a custom made prosthesis which is not available off the shelf now. Like for you want to put a big pelvic prosthesis here which will take 4-6 weeks. Then you don't want to delay and then you will give chemotherapy.
A 3D model here for planning jigs.
But now more or less you have a modular prosthesis which are available. Okay. So in those cases, why do you want to give chemotherapy? Because chemotherapy will ossify the tumor and it will sterilize your margins. It will make the planes a little better. Okay, so it helps in the surgical dissection. The response to chemotherapy is a prognostic marker. But although we have not seen a significant benefit of changing chemotherapy based on the response.
So can you just tell us what are the different chemotherapy regimes? Just enumerate if you know any chemotherapy regimes for osteosarcoma.
Yes, sir.
Tell us that drug which helps.
Sir, hydromethotrexate, doxorubicin, and cisplatin.
Very good. And one more drug?
Nikhil, any other drug?
So it could be methotrexate based or non-methotrexate based. In
Perfect.
non-methotrexate, IAP, sir, ifosfamide, adrimycin, and cisplatin.
Very nice. Very nice.
So
If
just
you know this much, we are
the
happy.
drugs and their doses and their gross complications. So about the surgical types of hemipelvectomy, again a common question asked in exams, types of hemipelvectomy. So can you tell us what are the types of hemipelvectomy? Yeah, Nikhil.
So it could be external hemipelvectomy or internal hemipelvectomy.
Internal, you can tell what are the types. Internal.
Internal hemipelvectomy, type 1 is iliac resection, type 2 is periacetabular resection, and type 3 is the pubic resection, and type 4 is posterior ileum along with the sacrum, tilly-sacral foramina.
Yeah. So, Sarfraz, what surgery will be required here? It's responded very well. You want to do limb salvage. So, what surgery will you do for this case?
Sir, type 2 hemipelvectomy, sir. Periacetabular resection, sir.
No. Or it will be combined something, type 1 plus partly main 2, partly 1 and partly 3. What do you think?
Yes.
Here? Only 2 will be okay, or you require some part of type 1 and some part of type 2 also here? Yeah, Nikhil?
So part of type 3 will be required.
Partly type 3 will be required. Joint will be saved or not? So joint for joint, what will you do here? So your joint is out then. So you are done. Type 2 means you are doing the periacetabular area.
Yes,
your
sir.
joint is gone. So how will you reconstruct here?
So
either we can go with the prosthesis, sir, saddle prosthesis can be used.
Perfect. Prosthesis. Okay, prosthesis is one.
Any other thing?
Composite allograft, sir.
Perfect. Very good. Allograft.
Autograft you can use. This bone, send it to radiotherapy, liquid nitrogen, put it back again. Autograft. Patient's own, that can be used.
Sir.
Yeah. Any other thing? You don't want to put anything. Just keep the head there. Put a mesh.
Mesh.
So can be used. A Prolene mesh, a composite type of mesh. Prolene with white frill, that type of mesh are there. No?
Prolene mesh.
Proceed mesh. So 2-layer mesh. Yeah. So can we use that?
Yes, sir.
Yeah. So that
so
can
just tell me the
multiple options are available here. So
what are you going to prefer, Nikhil and Sarfraz? If you want to do a limb salvage here, what will be the best? What will be your choice?
Better functional outcome is expected with saddle prosthesis, sir. So
perfect. Very good answer. Then wait for half an hour. We'll show you the functional outcomes in the next 15 minutes. No worries. So that is fine. I think the understanding is fine that if you are doing a salvage, you need to reconstruct the weight bearing axis. Okay, which goes from the femur to the hip joint to the spine. Okay, we need to do something to reconstruct the weight bearing axis. Whether you want to do a prosthesis, allograft, autograft, or mesh, I think we accept every answer whichever you say, because for a surgical oncologist, if you know this much also, we are happy. Okay, that you have to reconstruct the weight bearing axis of periacetabular resection.
Yes,
so
sir.
any other concerns when you choose a reconstruction option? Suppose this was an Ewing sarcoma. So any concerns of choosing a reconstruction option? So does a histology guides you in choosing a reconstruction? That was my question. Like, I'll reframe it.
No, sir.
Radiotherapy required, sir, for us. Ewing sarcoma, you require post-op radiotherapy, what he wants to ask you. So in which cases radiotherapy is required? Any specific indications of post-op RT in Ewing sarcoma?
So margin positive or close margin, sir.
So Ewing sarcoma surface with a large soft tissue component, axial site, you should add radiation.
Yes,
okay,
sir.
we are not discussing Ewings today, but yes, in this case, if this was a soft tissue component, whatever be the response, patient requires an adjuvant radiation.
Yes, sir.
So if I have to give a radiation, then I will avoid a prosthesis or a massive allograft or an autograft. Okay. So I want to minimize the hardware or a dead structure inside so that the risk of infection reduces. Fine. That is one thing. Suppose you operate this is an osteosarcoma, and your margins comes positive. Okay, so there are two things only. If your margin comes negative, you will continue with chemo.
Yes, sir.
Okay, suppose your margin comes positive, then how do you want to manage that situation?
Two options, sir. One is
Okay.
re-resection. If possible, yes, sir. If possible, then second
Yes.
option is, sir, radiotherapy, sir.
So does radiotherapy works in osteosarcoma?
It is said to be, sir, radio resistant, sir, but it is mentioned, sir, in NCCN guidelines, sir. That's why, sir.
Great. Nikhil, what do you want to do if your margin is positive?
If it's having sarcoma post-op RT.
No, it's osteo. It's osteo. We are not discussing EV. This is an osteosarcoma. Your margins are positive. What do you want to do?
Sir, re-resection, sir.
Re-resection. So I think more than that, first thing that you want to know is which margin is positive. Okay, whether it's a bony cut margin which has come positive, or whether it's some like a soft tissue margin which has come positive. Because I think most important thing when you dissect a pelvis is inspect your margins clinically. Okay, and ink any closest margin. Suppose the posterior iliac crest margin was positive, but you have already taken a cut through that bone. You have taken a cut through a tumor. So will a re-resection is going to help you in reducing the recurrence rate? Because you have already cut through the tumor and you have already caused a spillage of the tumor in the full pelvic cavity.
Yes.
So does a re-resection going to help you?
No, sir. That's what it is.
So both of you have told a re-resection, but technically re-resection might not help you that much because you have already cut through the tumor and you have already spilled the tumor cells in the pelvic cavity. Fine.
Yes, sir.
So yes, if there is a gross disease which is left, I agree that a re-resection can be useful. If it is a limb where the margin comes positive, we have to recommend an amputation in osteosarcoma because more or less you will not be able to do anything to improve the margin. But yes, in pelvis, the options are very limited because the cavity is already contaminated. And this is one area where you can add radiation. Although osteosarcoma is radio resistant, but this is one area because you cannot do anything else. Okay. Re-resection might not be useful.
5 minutes time. Dr.
Sorry?
Sujan.
Yeah.
Dr. Sujan, you have 5 minutes time.
We had 5 minutes time 7 minutes before, sir.
Yes, this is a case of Ewing sarcoma. So just we'll show something. So this was the X-ray.
We'll finish in 2 to 3 minutes, sir.
Yeah, we'll finish it. So this was the X-ray. So Nikhil, again, this is which bone is involved here? Nikhil.
So this is a immature skeletal X-ray.
No, just you say which bone is involved and just how it looks to you, benign or malignant. We have very less time here. Which bone is involved here? We have marked for you now.
Sir, sacrum, sir.
Oh, here, there is marking no. Arrows are here.
Left superior pubic ramus.
These red arrows are there.
Ischium and pubis are involved.
Pubis is involved. So this was Ewing sarcoma. So any other chemotherapy, which chemotherapy you give for Ewing?
Sir, VCDI, sir. Vincristine, doxorubicin,
Yes.
dactinomycin, and
Yes.
cyclophosphamide, sir, not dactinomycin.
Okay.
And cyclophosphamide is alternated every cycle with ifosfamide and etoposide.
Okay, so Nikhil, this was the CT scan. This was the MRI. What are the treatment options available here? One is, this is Ewing sarcoma. So you can do a surgery or you can give any other option here, alternative to surgery?
Definitive radiation can be given, sir.
Definitive radiation can be given. So this is one example that you can print a model. You plan your cuts exactly, what things can be done. So a case of hemipelvectomy, type 1+2, you remove the tumor. And you can check with the models and the jigs, how it is. These are the artery, vein and nerve. And you can use a mesh here from year to year. So that thing can be done. So this was the patient, Ewing sarcoma, and we resected him. So this was the scar. So this looks okay to you? The incisions?
Okay, sir.
This looks okay. So this was his first follow-up. And this was his 2023 follow-up. So he was 10 years boy when he presented to us, and it's nearly 8 years follow-up now. So walking well, and this was his X-ray. Just I will show his X-ray. This was his X-ray. So no acetabulum is there, but functionally it's very excellent. So alternative can be a radiotherapy. So we have seen a case of osteosarcoma, Ewing sarcoma, and this is the last thing. Again, in 2 minutes we'll finish. So case of sacrum, and we are examining him, this patient. So this was his video. So some fullness here. You palpate the tumor. Mark all the bony points, scapula, iliac crest. Mark the sacrum. Check the neurology, check the pulsation. Your limb is externally rotated. What Dr. Manish was saying, right limb is externally rotated. And he is having weakness in right leg. So unable to plantar flex his leg. He is unable to plantar flex and dorsiflex. Unable to move his ankle and toes. So in any spine case, you need to examine these parts.
Yes, sir.
He is able to dorsiflex, his great toe, L5, S1 and S2 are checked. And check the reflexes, check the sensations. And this was his MRI, showing a lesion in sacrum here. So Sarfraz, which bone is involved here? Which part of sacrum? This was his MRI. And
Yes, sir.
this was his MRI. Yeah.
Sir, S23.
S23. So do you think his bladder and bowel is also gone or it's intact here? The nerve supply of bladder, you know?
It's from, sir, two sympathetic and parasympathetic supply, sir. So parasympathetic supply is from, sir, L1 to L3, and so parasympathetics are S2 to 3, 4, sir. So probably he will have some bladder involvement, sir.
So which tumors are common, Nikhil, in this age group? Young patient, sacrum tumor. Again, at 20 years, so age was something 20 years here.
Sacral chordoma, sir.
Oh, young patient, Ewing sarcoma, can it be Ewing sarcoma? So one can be chordoma.
I think you can.
Yes, sir, this is last slide, sir.
Case, sir.
This is last slide, sir. Yeah, we can proceed with the next thing, sir. All 3 cases are done.
No, you can please tell us about this interesting case. Yeah.
So this was Ewing sarcoma.
So yeah, so just to like ask some more interesting question here. So I think you can read about that. So I just ask the question and not answer it. So suppose you are able to save unilateral S234, okay? And
Yes,
you
sir.
sacrifice unilateral S234, the contralateral, you save one side S234. What is the chance that the bladder wall function will be retained? Okay, that is the
sir.
first scenario. Second thing is you save bilateral S2, okay, but lose bilateral S34. Okay,
sir. Yes, sir.
what is the chance that the bladder wall will be retained? Okay. Third question is you save bilateral S2 with one S3. Lose one S3 and bilateral S4. What is the chance that the bladder wall will be retained? And fourth is you save S2 and S3 bilaterally and lose only bilateral S4. Okay.
Okay, sir.
What is the chance that the bladder wall will be retained? Okay, go and read about this. You will find this in literature.
Okay, thank you, sir.
Yeah.
So I think
I'll stop my sharing next thing. Yeah.
So thank you so much, Dr. Abhijit, for those wonderful cases. What we'll do is we'll move on to the expert talk now. We request Dr. Manish Pruthi to kindly load up his slides. When he does so, I'll ask first our moderator and then Dr. Manish to kindly rate our students for today and have they passed their examination and any tips for them in the coming exam.
They have passed their exams. Just they need to read a bit more. They answer very properly.
And more than that, I feel they need to be more organized. When you are thinking about a case, okay, I think it is good to revise before you present, although it was a very small time. But good to think that what you are dealing with, then your answer should come in that flow. Okay, everyone knows, and I think at MCH level or a DNB surgeon level, we know how to examine a case, but we have to, our answers should be in a flow. So that is important. So if you are more organized, okay, this is what I am thinking, and these are the relevant investigations, then I think you will not fumble and you will not say unnecessary investigations. So that saves a lot of time of yours and examiners, and actually avoids unnecessary questions which no one wants to ask. But if you tell me LDH, then I am going to ask you about what is the role of LDH in Ewing sarcoma, and then you will have no answer about that. So isliye answer what you know, okay, and answer only specific. And if you are more organized, then I think it will help you.
Thank you, sir.
Thank you so much, sir. You can share your screen, and we are all yours for your expert talks. Please proceed.
Yeah.
I request Dr. Abhijit Salonke to kindly stay till the end, because we have a few
I'm here.
waiting.
I'm here. Yeah.
So my slides are visible.
Yeah, perfectly.
And am I audible? Yeah, I think I am audible. Yeah. So we'll be discussing about pelvic girdle tumors, and I know the audience is a surgical oncologist today, and it might be a little boring for you guys, especially when I'm going to show you some evidence in terms of reconstruction. But I think in next 25 minutes, if you will get to know like what works best for the pelvic tumors, and secondly, if the case comes in exam, maybe you can give a little better answers. Okay. So I think few thoughts which comes to our mind when we see a pelvic tumors is how common are these? Are the pelvic resections safe? How to decide on surgical options? Then what are the reconstruction options? And the last is what is the outcome if we are thinking about operating a pelvic tumor? So I'll answer this first and the last question first, like how common are these tumors and what is the outcome? So this was our paper way back in 2014, which was published in European Journal of Surgical Oncology from Tata Memorial Hospital, which we had almost 103 pelvic tumors, which we have operated in a period of 8.5 years. So that is like almost 12 to 13 cases in a year. So that means we are operating more than one pelvic tumor in a month. This is only internal hemipelvectomy. So if you add external hemipelvectomy, then we are operating more than 2 to 3 pelvic tumor in a month. That makes a huge number, especially for a tertiary referral center. So second thing is, what is the outcome? If you see in this, our overall survival was 67% at 5 years. So the outcome is not very bad in pelvic tumors if you follow the principles well. So these tumors are not very much uncommon. In a tertiary referral center, in most of the major institutes, we'll see a lot of these tumors. And the outcome is good if you are able to do a good, give them a good treatment. So now the most important question as a surgical oncologist that you are faced with is how to decide whether this patient needs an external hemipelvectomy or an amputation through pelvis or an internal hemipelvectomy. And as Dr. Abhijit was discussing, like what part of pelvis is going to go, what are the combinations or a permutation and combination that you are going to do. So I think the most simple guideline is this. So you should offer a patient internal hemipelvectomy, which is a limb salvage surgery of pelvis, when you can save 2 out of these 3 structures. This is a very broad guideline, but this works very well. So if you are able to save femoral nerve, neurovascular bundle along with sciatic nerve, you are losing a hip joint, you can still do an internal hemi. If you are losing a femoral neurovascular bundle, but you are saving the sciatic nerve and the hip joint, you can still do an internal hemi, or the other way. So basic thing is you are able to save 2 out of the 3 critical structures, and you can do an internal hemipelvectomy. I think as far as the surgical oncologists are concerned, this is a very broad but a useful guideline that you should remember. So now comes, so like many of the cases will be involving the sacral canal or the sacral roots, and more or less if the tumor involves the sacral canal or the sacral roots, we are not able to do a resection with a clear margin, and most of these patients goes for a definitive radiation. So if the tumor is involving the lateral part of sacrum, yes, we can do a safe margin surgery. But yes, if it involves the sacral foramina, then it becomes very challenging. Yes, now with the navigation, with advances in surgery, we can do a sacrifice of the one side sacral root and still think of clear margins. But more or less, like for a basic understanding, if tumor involves the sacral canal, the clear margin resection is not feasible. So as far as the type of resections are concerned, you guys have spoken very well. Type 1 is iliac, type 2 is periacetabular, type 3 is pubic, and type 4 is a sacral resection. But more or less, we are doing a combination, like either it is 2 plus 1 or combined 1, 2, 3 or 1, 2, 3, 4. More or less, it will not be an isolated resection. It will be a combination of resection. So now coming to external hemipelvectomy, what are the types of external hemipelvectomies that do? This is the classical external hemipelvectomy, where the posterior cut goes through the posterior sacroiliac joint, anterior cut goes through the symphysis, the ligation is of the common iliac vessel, and it is a flap, which is a posterior flap-based external hemipelvectomy. When you talk about extended external hemipelvectomy, then our posterior cut shifts to the sacral foramina. So basically, the tumor is involving the ilium with the lateral sacrum. So, and if you remove the tumor from the sacral foramina, it is called as extended external hemipelvectomy. What is modified? When you are able to save the hypogastric or the internal iliac vessels, you are able to save the flap vascularity by saving the superior as well as the inferior gluteal supply to the gluteus maximus, and that is called as a modified external hemipelvectomy. What is a compound external hemipelvectomy? It is a pelvic resection along with a visceral resection. So whether you are using a part of bladder or part of bowel or any other important visceral structure in the pelvis, this is called as compound external hemipelvectomy. And very rarely the posterior compartment is completely contaminated. And in those cases, you can do an anterior flap external hemipelvectomy, in which you dissect the femoral nerve or femoral artery right up to the sartorial canal, preserve the perforators from the femoral artery to the anterior skin, and use an anterior flap to cover the posterior defect. So this we call as an anterior flap external hemipelvectomy. So like the challenge that the pelvic tumor faces to a surgeon is a larger disease volume. And because of that volume, they become surgically challenging, and it is very difficult to achieve wide margins there. And the reconstruction options are quite complex, and we'll be discussing that in a little more details. So this was again our paper of the pelvic tumors, and we had 103 patients. And as you can see that the resections which do not involve acetabulum had a mean duration of surgery of 4.5 hours, as compared to resections which were involving the acetabulum have a mean duration of surgery of 6.8 hours, with a mean blood loss in first group around 2500 ml and the second group around 4500 ml. But just see the range. The blood loss can go as high as 10 liters or 13 liters in pelvic surgery. So these are major surgeries and you should be prepared well. The second important problem that we face is a large disease volume, because pelvis, the tumors are deep seated, so they usually grow very long, very big before they present. And as you can see in this pelvic chondrosarcoma, it is going right up to the infrarenal region. They are surgically challenging, as seen in our paper also, like out of 103, total of 45 patients had complications, which gives us a complication rate of 44%. And a surgical intervention for a complication was required in 26 patients. So pelvic tumors are challenging. We should be prepared for that. A vascular injury, bladder injury, nerve palsies, infections are quite common. And the other thing is difficulty in achieving wide margins, as like you can see in our data also, almost we had 20% involved margins. So coming to the challenging aspect in pelvic tumor after the resection is reconstruction. So when our resection involves only the ilium or only the sacral area or only the pubis, we do not need to reconstruct. So resection involving type 1 isolated, type 4, type 3, we are not reconstructing. And these patients usually get a good functional outcome. Like in our data, we had 38 patients which did not involve the acetabular resections. And the functional score was 27 out of 30, which is 90% functional score. And as you can see in this patient, the function, he was able to do almost all the activities, and the function was quite good of a type 1 resection. So type 1 resections, we are not reconstructing. And it is not only our data, this is data from Canadian group, which also shows a type 1 or 4 resection when we are not reconstructing, the functional outcome is quite good. And in there, the mean functional score was 21.1. So when we are losing the acetabulum, like as shown by Dr. Abhijit in the first case, we have to reconstruct. So what are the reconstruction options here? The first is an extracorporeal radiation, where Dr. Abhijit was telling using an autograft, like we have a cuts proximally and in the medial side in this case. So we just recycle this bone and put it back by doing an extracorporeal radiation. Or we can do an arthrodesis as seen in this case. We take the cuts, we try to arthrodese the remaining part of the femur with the pelvis. Or we can use a proline mesh as Dr. Salunke was suggesting, and suture it around the femoral head and to the rest of the pelvis. So these are the three common reconstruction that we use, and very rarely you can use a pelvic prosthesis also like this, in which we are losing the half of the pelvis and we put a pelvic with a proximal femur prosthesis. So now the question comes, what a surgeon or a patient expects from a reconstruction option. So these are the common things that you expect in general from a reconstruction option, which is an availability, the durability, the cost effectiveness, allowing the early rehab, which is should not interfere with the adjuvant treatment, give a good functional outcome with a low complication. This is very simple, but it becomes very complex in pelvis. So I'll just discuss these one by one so that you understand what works best for a pelvic resection. Going to the good functional outcome. So this is a case which was reconstructed on a case of an actually adamantinoma of the pelvis, which was reconstructed with only a proline mesh. Okay, and as you can see, so this is the patient who is walking with a proline mesh. You get a shortening, but patient still gets a stable gait. So this is how, if you can see the slide above, this is how you suture the proline mesh. First, you suture all around the base of the capsule, along the intertrochanteric line, and the other part of the mesh, you drill holes in the sacrum or in the remaining pelvis, and you suture it there. And once you suture it, you can see the image below. You get a very like a tight suturing, so that the pelvis the hip does not move, and ultimately it fibroses and give a good functional outcome. Another patient, again reconstructed with a mesh pseudoarthrosis in a similar manner. So you can see at 4 years, she is having a quietly decently stable hip. She is even able to dance. You can see the stability of the hip. She can walk quite nicely without like you noticing that her gait is abnormal, and she even worked the Miss Cancer Survivor pageant. So a mesh pseudoarthrosis gives a quite an acceptable functional outcome. And this is not only our cases or my cases. This is a data which is from all around the world. This is now data which from Ozaki et al., and which shows that a pelvic prosthesis gives a quite an inferior function as compared to a hip transposition, which gives a much better functional outcome. Another data now from the Birmingham group, this shows that for the acetabular resections, the Musculoskeletal Tumor Society scores were significantly better in patients with hip transposition as compared to those with any structural reconstruction, which include allograft, prosthesis, or anything. So they also concluded that the mesh is quite safe and gives a superior outcome. Now, this is our data now from MSKCC, which also shows that the overall high complications are associated with massive implants and allografts in pelvis. And avoiding these major complications seems to be crucial regardless of type of reconstruction to get a best function. So they also concluded that the hip transposition or the mesh works have the lowest overall complication rates. So even in our data, we have used mesh in maximum patients, and our functional results were the functional MSTS was 22, which was better in younger patients as compared to the older patient, which is 26 versus 19. Young patients usually do much better with a mesh pseudoarthrosis. The second question is what we expect from a reconstruction is a low complications. And as we understand that these are the major complications that we can see in a pelvic resection, which could be bleeding, injury to neurovascular structures, injury to flap necrosis, infection, limb length discrepancy, and involved margin. And out of these two, the infection and limb length discrepancy definitely relates to the type of reconstruction that you are doing. Rest is based on the surgery. But yes, sometimes the involved margin is also a factor which is based on the reconstruction more than the surgical decision. I'll discuss that in a while. So basically, this is the data now which shows a reconstruction of pelvis tumors in children and adolescents. They have 30 patients, And there you can see the amount of reoperations which are required in the operation. Allograft prosthesis require the 3.5 reoperations. Prosthesis on alone require 2.5, while other or no reconstruction require only 0.8 reoperations. So in pediatric patients also, the number of reoperations in mesh or no reconstruction was much lesser as compared to any other reconstruction. This is again the same data by Ozaki et al., where they have qualified the type of complications, and prosthesis and allograft were having more of an infection as compared to hip transposition, where the complications were minor. That is what they concluded, that none of the complications were serious enough, which led to the failure of reconstruction, while it was not in the case of prosthesis and allograft. So our cases also, as I have shown, a wound infection was seen in 19 patients, which was much lesser as compared to the literature, because we have chosen Prolene mesh in more or less almost 70% of our patients. So again, the data from the Birmingham group for a pelvic prosthesis, and you can see that the one or more complications occurred in 58.1% of patients of prosthesis, and they have concluded that this method is associated with high morbidity. So beware when you are asking for a prosthesis in a pelvic resection. So these are like sometimes very scary, and you more or less end up removing them. Now the other complication or the most common problem that you face with the Prolene mesh is what people call a limb length discrepancy or a shortening because of a flail hip. But not always the shortening will be significant. As you can see, when you are able to save some part of ilium above, you can see the level of lesser trochanter. It is not significantly different. The shortening was not more than an inch in this case. Similar other case of a chondrosarcoma, you can see that the lesser trochanter was almost at a similar levels. If you are able to save the ilium, a part of ilium, then the shortening is not very bad. But yes, if you are removing the full 1 + 2 + 3, then definitely the shortening will be between 6 to 8 centimeter, which has to be compensated by shoe raise. But doing any major reconstruction here also, which leads to a failure, as I've discussed earlier, and which should be discouraged. So and especially when you're doing a pediatric reconstructions, if you're able to save the inferior part of the acetabulum, like in this case, you suture the femoral head to the inferior acetabulum, and your shortening will not be very significant, and your function will be superior. So we have published our results of a pediatric pelvic tumor separately, and you can see that the mean MSTS score where the acetabulum was resected was 25 in 30 patients. We had 18 acetabular resections. So if even in pediatric patient, the function with the mesh is much more superior as compared to any other reconstructions. Coming to involved margins, thus choosing a reconstruction guides your margins. There is some data which supports that. So this was a paper which shows that the primary advantage of hip transposition is the fact that the resection can be done without looking at the reconstructions. And that is why they had the very low rates of inadequate margins, as well as remarkably low rate of local recurrence. Similar was our data. We also had a very low recurrence rate because we have also predominantly used a Prolene mesh for reconstruction. So the other important thing that when you are choosing a pelvic reconstruction is it should not interfere with adjuvant treatment. This is what I was highlighting when Dr. Abhijit was showing. Like, is Ewing's in pelvic Ewing sarcoma, should all patients receive preoperative or adjuvant radiotherapy? So the answer is yes. More or less, the Ewing sarcoma of pelvis will require radiation. And when you are putting a prosthesis and you are radiating, the risk of infection almost becomes 3 times. So more or less, the pelvic prosthesis, if you radiate, the prosthesis is going to come out. Same with allograft or same with massive autograft. So more or less, in pelvic Ewing sarcoma, if you are planning a radiation which will be required, you should use a minimal reconstructions. As far as the availability, durability, and the cost effectiveness of mesh goes, I think you all are surgeons and you know the cost of a Prolene mesh, which is not more than 950 rupees for a 15 by 15 mesh, or maybe 2000 rupees for a 30 by 30 mesh. So coming to the rehab part of using a Prolene mesh in a pelvic reconstruction, typically we make them sit from first to second post-operative day. Out of bed shifting to wheelchair or side chair is permitted after 6 weeks, and weight bearing ambulation is started at 12 weeks. But yes, there is some data now. This is a paper from Japan, which they have used a temporary external fixator after a hip transposition to improve the early mobility and reduce the pain. This can be done. We have never tried, but yes, this is one option. where you can do an early mobilization, maybe less than 6 weeks, and reduce the pain which a patient can have in a post-operative period. So to conclude that the pelvic sarcomas are not very not very common, but not uncommon also, we will see some cases in our practice. Limb salvage resections are possible, but requires expertise as well as a multidisciplinary backup. By multidisciplinary, I do not only mean presence of medical or a radiation oncologist, but yes, you sometimes require a neurosurgeon, you require a general surgeon, you require a GI surgeon, or a gynec surgeon also, especially in pelvic E-wings, to do an ovarian transfer when you are contemplating a limb salvage resection in pelvic tumors. The reconstruction choice depends upon many factors, but yes, meshplasty or hip transposition gives an acceptable functional outcome with minimal complications. Nowadays, I have not gone into this. Nowadays, we are using computed navigation in pelvic tumors to have more precise cuts, which help in improving our margins and ultimate outcome. So with this, I think this is more than enough for you guys. With this, I would like to thank you for patient listening, and I'm happy to take any questions.
Thank you so much, Dr. Manish. There are a few questions for both our examiners, so we move on to our final segment.
Dr. Srijan, you are muted.
Am I audible? Hello?
Yeah.
Yeah, I am audible?
Yes, you are audible.
Okay.
Srijan, we can't hear you.
You can't?
I can't hear you actually. I don't know whether.
Okay. Dr. Abhijit, are you able to hear me?
Yes, I am able to hear you.
Okay. So anyway, I've put on the questions here and I've labeled the questions for the specific examiner.
Yes.
So if Dr. Manish is not able to hear me, maybe Dr. Abhijit, you can start taking up the questions.
Yes.
Abhijit, can you hear? Because I can't hear anyone.
Yes, we are able to hear you.
Okay. So Dr. Abhijit, could you start with the first questions?
Yeah. What are the signs of unresectability for external hemipelvectomy? So Dr. Manish said, what are the signs that he said for internal hemipelvectomy? For external hemipelvectomy, you think that the closure will be not possible. So that can be one thing that you think that the closure is not possible. The last thing, again, it's same, hemicorpectomy is standard with real world. So I have not seen any hemicorpectomy, but in future, if any case is there, we will do it. But still, I have not seen any hemicorpectomy still now.
Okay. So Dr. Manish, your take on the first and the last question.
Sorry, actually, I had some headphone issue. I could not hear the questions. Can you please repeat it?
Yeah, so we are discussing the first and the last question. What are the signs of unresectability for external hemipelvectomy? And is hemicorporectomy a standard surgery with real world indications?
Yeah. So basically, unresectability, I think I have touched upon that if the tumor involves the sacral foramina or the sacral canal, more or less it becomes unresectable. Even getting a clear margin in external hemipelvectomy might not be possible. Okay. Yes, but now with the advances, especially with a very good MRI and navigation, so what you can do is you can still think of getting a clear margin by resecting one side of the sacral roots. Okay. And still, if you save one side ipsilateral, I can give you that answer. If you save contralateral S2, 3, 4, you still have a 70% chance of a bladder bowel function retainment. So technically, if the tumor involves only the one side of sacral root, you can still consider an amputation through the sacral foramina or a resection through the sacral foramina and can get clear margin. But yes, if it involves beyond that or if it involves the other side of a pelvis, then I think it is unresectable. Yes. Right. Regarding the soft tissue cover, everything we can still consider a flap or a free flap to cover the defect. But yes, this is, I think, the most important of unresectability.
Right.
So now the question comes about hemicorpectomy, a standard surgery with real world indication. So frankly, I have never done it. And if the need arises also, maybe I'll prefer some other less morbid things than considering an hemicorporectomy, because I think more than a surgery here is the patient safety. Okay, so anyway, a pelvic surgery, as I was showing you, our blood loss has gone up to 13 liters, and I do not know how much blood I am going to lose in a hemicorpectomy. And now with an evidence, now with the availability of protons, availability of Dr. Laskar's paper of using dose escalated radiation in Ewing sarcoma, I think many of these unresectable should undergo a dose escalated radiation therapy or protons, which can give them at least a less morbid thing, okay, and maybe a good survival advantage. So today's world, I don't think there is any role of doing an hemicorporectomy if you have an availability of a high dose radiation or a protons. So I will not advise that. Yes, but maybe some challenging surgeon can take over, but I think it is too risky and quite unsafe in today's world.
Thank you so much for that answer, both our examiners. We'll move on to the next point, which is to Dr. Manish. Can you please explain the rationale and the indications for navigation surgery?
So navigation is, many people comes to our OPD and ask, sir, are you going to use navigation in pelvis especially? And because now we have navigation in TMH, so most of them comes and ask us, sir, are you going to use navigation? So my answer is very simple, going from your office to your home, if you know the way, do you really switch on the Google Maps? So Google Maps is a navigation. So navigation is a tool. Okay, it is not absolutely essential. So when you know that your cut, your disease in acetabulum, you are going to take a cut in the posterior ileum and you are quite sure about your cuts, you know that there is no disease there, I don't think you need a navigation. Okay, because more or less you're going to expose that area, you have good bony landmark. But the role of navigation comes when there's a big anterior soft tissue component. You cannot do an access anteriorly. Okay, you only want to take a posterior cut, then you need a navigation because half of the bony landmarks are obscured. You are not able to see. Or when there's a disease which is going right in the sacral ala and you want to take a close cut, but a clear cut. Okay, and those areas where you want to be very precise in your cuts, you need to use navigation. So currently the indication and the rationale for a learning case, we plan navigation for all pelvic tumors. Okay, but yes, many of the times we will not use it because when we know that we can take the cuts with our standard C-arm or with our standard landmarks and we know we are far from the tumor, we are not using navigation. But yes, navigation is useful when you are planning a close margins or when the tumor anatomy or the tumor size prevents you from using a normal anatomical landmark.
Dr. Abhijit, any thing to add?
No, this is correct what Dr. Manish has said. So it is a guiding tool to go more precise if you think your margins are close. So then it is recommended, or you can, if you don't have navigation also, you can use jigs. So you make a model, make a 3D printed jig, apply it and take your cuts. So that can be used at all the centers across the globe. Navigation is limited to very less centers. So you don't have that. Still you can manage with a jig for the patient and take perfect cuts with the help of jigs.
Okay, point well taken, sir. We'll come to the next question, which is how to manage unresectable low-grade chondrosarcoma.
So you have one option of radiation. Second is palliative chemo. Not that great role in chondrosarcoma, but you think it's unresectable, then you can use some chemo and radiation. Again, proton can be used again. One or two centers across country are having it. So very limited knowledge about that and how much it will help in these cases.
Yeah, so Srijan, very interesting scenario that I remember of low-grade unresectable chondrosarcoma. So I was at Birmingham and there was a low-grade chondrosarcoma in the pelvis, supraacetabular region. And that was missed actually in the initial X-rays 8 years back. Okay, then the patient presented over the 8 years. He had a mild hip pain, but he never showed. And then 8 years down the line, he presented with a full iliac crest lesion, which is now that low-grade chondrosarcoma from supraacetabular now has involved the full ilium. Okay, now that patient required a complete iliac resection, technically with a acetabular resection. But that patient had a bad COPD, a chronic obstructive pulmonary disease. And the decision that MDJC took is not to do anything at that moment also. And they were happy that they missed the lesion previously 8 years back, because a low-grade chondrosarcoma has grown very slowly, but that patient remained functional for 8 years. With that bad COPD, with losing acetabulum, he would not have been functional. So, and he was not operated at that moment also. So low-grade chondrosarcomas, first thing, in pelvis, I think there's nothing like a low-grade. Okay, even the biopsy shows a low-grade chondrosarcoma in pelvis, it will turn out to be a grade 2 or grade 3. So more or less, a chondrosarcoma in pelvis will be grade 2 to grade 3. Unlikely will be low grade unless it is a secondary chondrosarcoma. So more or less you have to offer a surgery. But when it is an unresectable low grade, so you have an option of giving radiation versus observing. Because when you have decided now it is unresectable, you can't do much. So then better to radiate or do give some local treatment rather than systemic. That is what I feel. Because usually the patient is not going to die with a systemic metastasis if you are sure about your diagnosis. But in pelvis, there is nothing like low grade. Even if you get a grade 1, the final report will show you a grade 2 or 3.
I think that's an excellent overall view on this question. We'll move on to the last thing for today, which is for Ewing sarcoma. Is there any radical radiation dose or modality that is equivalent to surgical resection?
So Abhijit, you want to take on that or should I answer? So yeah. So Abhijit, you are taking on that or I have
No, you answer now.
Okay. So Ewing sarcoma. So first thing is we are discussing about pelvis only today, na? Yeah. So for Ewing sarcoma of pelvis, as I have emphasized in two to three times, more or less all pelvic Ewing sarcoma will require an adjuvant radiation. Okay. Sometimes we give a new adjuvant radiation to reduce the tumor size to ease in surgery, but more or less radiation is an important modality in Ewing sarcoma, and we need to choose a reconstruction which depends upon which knows that patient is going to get a radiation. Now coming to an Ewing sarcoma which is involving the sacrum, in which you decide that now the resection is not feasible, the R0 is not possible. So now those cases you want to treat with definitive radiation and not operating. So Dr. Laskar in TMH, who is our radiation oncologist, sir has done a trial of giving a high dose radiation, which is we call it the dose escalation trial. Okay. Normally, we are giving a dose up to 60 grays in Ewing as a definitive radiation. But in dose escalation, we have gone up to 70 to 72 grays. Okay. So, and in those doses, we have found a very good local control in Ewing sarcoma, which was comparable to the published surgical literature. So yes, we have some data now, and this paper is being published, has been published, and you can go through that. I think it is the first Dr. Laskar, and the trial name is dose escalation trial for Ewing sarcoma. And you can see go through the results. Yes, high dose radiation, we call it a dose escalation radiation, in Ewing sarcoma can give an acceptable local control rates in unresectable. But still the preferred modality will be a surgery plus radiation. If it is unresectable, consider dose escalation.
So we have tried to compare data of surgery versus surgery plus RT versus definitive RT. So surgery is always a better surgery plus RT or only surgery as compared to radiation. So survival rates of surgery plus RT will be 70 to 80% survival rates. Of only radiation, 40 to 50%. So always recommended surgery is always a better. So we are trying to publish our data and publish a meta-analysis on this topic. So soon we can say exact data, what is that numbers. But it's nearly 60 to 70% survival rate with surgery plus RT. And only RT 40 to 50% survival rates.
In fact, you guys will be surprised that there was a Euro-Ewing's data, Euro-Ewing's 99 trial data, in which shows that the best benefit of adding radiation in Ewing sarcoma in patients was in the patients who had 100% necrosis. Okay, especially in the axial sites. What happens is the tumor is very big, and when there is 100% necrosis, the tumor shrinks. Okay, so more or less, when you are resecting, you are not resecting the pre-chemotherapy volume, because pre-chemotherapy, it might be abutting the bladder wall, might be abutting the bowel. But when you resect, you are not resecting all that. Okay, so the best benefit of local control was in the patients who had 100% necrosis. This was the Euro Evings 99 data. So the title of the paper was "Can Post-Operative Radiation can be omitted from Ewing sarcoma?" So very good paper. So they have shown that the patient who get a 100% necrosis in Ewings will benefit from the adjuvant radiation most, because the tumor is shrinking so much that you are not resecting the pre-chemotherapy volume. So Ewings, more or less, if less than 90, you are adding radiation. 100% also you have to add radiation. So more or less you need to add radiation.
So I think that finishes the Q&A part for the session today. From my side, I would like to thank both the examiners for patiently going through the whole case discussion and repeating things for the benefit of students. I hope the residents learned, and the good thing is this webinar will be available on YouTube. You can search IASO webinars, and if there's any segment that you want to relook, it's there for posterity. I invite Dr. Caleb Harris, who's a former executive committee member of IASO, who shall be representing IASO in delivering the vote of thanks for.
He's a good friend of us. He's a good friend of Manish and me. So,
Caleb,
to him.
I am surprised how you are there.
We'll talk. So on behalf of IASO and Dr. P.S. Rao, big thank you to all of you who participated today. And especially big thank you to Manish for making a crisp and clear presentation. And thank you to Abhijit for taking so much pains to shoot all those videos of those patients. And that is really helpful. And to both of the examinees, Dr. Sarfaraz and Dr. Nikhil, really commend your boldness, I would say, to come forward to present a case like this on a national platform, even though we know that sometimes you might not have even seen many such cases in the past. So big thank you to all. And we also thank Dr. Sadasivam and other seniors for being there, for participating in this program. So big thank you to all of you. Good night.
Thank you, sir.
Thank you. Thanks, Dr. Surujan.
Thank you, sir. Thank you, Obram. Good evening. We'll then have a good night. We'll be seeing all of you again in a span of 2 weeks with another topic in the IASO Masterclass series. Thank you.
Thank you.
Thank you, guys. Thank you very much, Dr.